Welcome to the weekly Neurology Deep Dive. Today we're focusing on a specific study, the ADVANCE-CIDP IVIG trial. It looked into using intravenous immunoglobulin 10%, that's IVIG 10%, for treating relapses in CIDP. Just a quick note up front. This is purely for education. No commercial goals here, and it's a summary. For the full picture, you absolutely need to read the original paper published back in the European Journal of Neurology, 2025. Now, as neurologists, I'm sure you're interested in effective ways to manage CIDP relapse in your daily practice. So our mission here is to pull out the key data, things like responder rates, how quickly patients improved, the safety profile, basically, the practical points from this trial.
Exactly. And maybe just to set the stage quickly, CIDP, chronic inflammatory demyelinating polyradiculoneuropathy.
Right.
It's an autoimmune condition. You get inflammation, demyelination in the peripheral nerves. Leads to weakness, sensory problems, and current guidelines do recommend IVIG as a first-line treatment option.
Right. So this trial, ADVANCE-CIDP IVIG, how is it set up specifically to look at relapse?
Well, it was actually an open-label phase. It followed on from the ADVANCE-CIDP 1 trial. That earlier trial was looking at subcutaneous immunoglobulin, or SCIG.
Okay, so who was included in this IVIG part?
They included adult patients who had a confirmed CIDP relapse during that previous ADVANCE-CIDP 1 trial. A relapse was defined pretty clearly, at least a 1-point increase in their adjusted INCAT disability score compared to where they started before that treatment. And these patients had been on either placebo or a form of facilitated SCIG 10% in that parent study when they relapsed.
Got it. And the treatment they received in this relapse study?
It was IVIG 10%. They started with an induction dose, 2 grams per kilogram. Then they moved to maintenance infusions every 3 weeks, and that lasted for 6 months. The maintenance dose was set to match the monthly equivalent IVIG dose they were on before they even entered the parent trial. And there was a cap on the daily dose, 100 grams per 1,000 milliliters.
Okay, let's get to the results. The primary outcome was the responder rate, right? Defined as that 1-point decrease in adjusted INCAT score by the end.
Yes, exactly. A decrease of at least 1 point at treatment cessation compared to their score just before starting the IVIG 10%. They looked specifically at the group who had relapsed while on placebo in the parent trial.
And what did they find in that group?
Quite striking. In that placebo relapse group, there were 16 patients. The responder rate was 100%. The 95% confidence interval was about 81% to 100%.
100%. And what about the overall group, including those who relapsed on the facilitated SCIG?
So the total relapse population was 20 patients. That included 4 who relapsed on the facilitated SCIG. In that combined group, the responder rate was 95%. Confidence interval there, roughly 76% to 99%. There was one patient from that facilitated SCIG relapse group who initially responded but then worsened again before the 6 months were up.
Interesting nuance there. Did the severity of the relapse matter for the placebo group's response?
That's a good point. They looked at that. And no, the 100% responder rate in the placebo relapse group held true whether the initial INCAT score increase was relatively small, say 2 points or less, or more significant, greater than 2 points.
That consistency is definitely notable. What about the timing? How quickly did patients start showing functional improvement?
The median time to see that functional improvement, again, at least a 1-point drop in the adjusted INCAT score, was 25 days across all the patients combined.
25 days median.
Yes. But there was a difference when you split the groups. For those who relapsed on placebo, the median time was quicker, around 23 days. For the smaller group who relapsed while on the facilitated SCI, it took longer, a median of 65 days.
23 versus 65 days. That difference is certainly something to consider.
It does raise questions perhaps about response kinetics depending on what therapy the patient was failing, you could say.
Beyond the INCAT score, did they look at other measures, like changes in overall disability perception or, say, grip strength?
They did. At the end of the 6 months, the average change, the mean change in the adjusted INCAT score from the pre-IVIG baseline was a decrease of 1.9 points. The median decrease was 1 point. They also measured grip strength in the more affected hand. The mean improvement there was an increase of 12.2 kilopascals. And they used the RODS, the Rasch-Built Overall Disability Scale Centile Score. That showed a mean increase of about 13 points at week 24.
And the RODS gives a broader picture of disability from the patient's view.
Exactly. It captures more aspects of daily life impact.
So improvements seen across different scales. How about getting back to where they were before the relapse, the prior baseline function?
Good question. They tracked that relative to the baseline before the subcutaneous immunoglobulin in the parent trial.
Mm,
For patients whose grip strength had dropped by at least 8 kilopage during that parent trial, almost 90%, 8 out of 9, got back to or even exceeded their pre-SEI baseline grip strength after the IVIG 10% treatment.
that's quite a recovery.
Yes. And for the RDS, looking at raw scores that worsened by at least 4 points, about two-thirds, 67%, that's 8 out of 12, returned to or improved from their pre-SEI baseline. And if you look at the centile RDS scores, for those who dropped by at least 8 points, nearly 80%, 78%, or 7 out of 9, recovered to or improved from that pre-SEI baseline.
So it really suggests a good potential for functional recovery with this IVIG rescue treatment.
The data certainly points that way, yeah.
Okay, let's switch gears to safety. What did the study show regarding adverse events?
Over the 6 months, there were 60 adverse events reported. This occurred in 70% of the patients. If you calculate the rate, it was about 0.15 events per infusion, or 3 events per patient across the study duration.
And what were the common ones?
The most frequent, reported in more than 5% of patients, were headache that was seen in 40%, and pyrexia, or fever, in 10%.
40% for headache is fairly typical for IVIG, isn't it?
It is, yes, it's a known side effect. But importantly, the study found no local adverse events related to the infusion itself. Also, no serious adverse events, no deaths, and no adverse events that actually caused anyone to stop the IVIG treatment.
That's crucial. Any issues with tolerating the infusion rate?
Very few. Less than 1% of all the infusions given needed the rate to be slowed down or the infusion paused due to tolerability problems.
Okay, so pulling all this together, the efficacy, the recovery potential, the safety profile, what are the main practical takeaways for neurologists managing CIDP relapse?
Well, I think this study provides pretty solid evidence that IVIG 10% works and is safe as a rescue treatment when patients with CIDP relapse. This is specifically in patients who, have previously shown they respond to immunoglobulin therapy in general. The high responder rates, especially that 100% in the placebo relapse group, are quite compelling, and that median time to improvement of around 25 days overall gives a useful time frame to potentially expect clinical benefit when you start this treatment for a relapse.
So this deep dive into the ADVANCE-CIDP IVIG trial really highlights IVIG 10% as a potentially strong option for CIDP relapses. We saw high responder rates, clear functional improvements, the data on time to improvement around that 25-day median, and the manageable safety profile offer valuable points for clinical decision-making when you have a patient in front of you experiencing a relapse. Of course, we have to remember this is a summary. The full paper has more nuances about patient selection, individual variability. It's essential reading. It does make you think, though, how these findings might apply or inform treatment strategies when patients relapse, perhaps while on other maintenance therapies. What further questions does this raise for you in your practice about managing these tricky CIDP relapses? We really encourage digging into the original publication to consider all its implications.